cardiothoracic and liver transplant anaesthetist based here at Sir Charles Gardner Hospital, and he got the day off. Thanks for coming. He's also got an appointment at Bart's Heart Centre in London, where he did his fellowship training, and he's Deputy Director of Research at Sir Charles Gardner, and his own research interests have lots to do with what we're talking about this week. Coagulopathy in end-stage liver disease, transfusion triggers in liver transplant patients, the use of cell salvage technologies, extracorporeal circulation support, and diagnostic accuracy of point-of-care coagulation testing. Welcome, James, to talk on fibrinogen concentrates and cryo.
Thanks for that introduction, and thank you for the opportunity to talk here about a subject that I'm quite interested in. My caveat is I am cardiothoracics and liver, and I do not do any trauma, and so this is kind of where my experience kind of lies. So take it with a grain of salt if you don't agree with it, and please be kind during the question, even though the THOR guys are asking otherwise. So now I need to get used to this guy, the green one. Excellent. So what we're going to do a little bit is talk through the two main big elephants in the room, a very topical subject. I'm sure there'll be people in different camps. But first of all, because it's what's in the bag, I'll talk through what's in the bag of each of them, go through some of the kind of pros and cons, then we'll summarise with a bit of science and then talk about what I kind of do in my clinical practice. And so I'll start with, first of all, I'll start with plasma. So there is cryoprecipitate in plasma. It's about 2 grams per litre, and that's probably about as far as I'll go because I've got 20 minutes to talk about two extremely topical items on the agenda. So cryo. So cryo can be derived by either aphoresed or by whole blood cryoprecipitate. At about 1 to 6 degrees, it becomes insoluble. They take that insoluble solution off the top of the surface, and then they refreeze it. And so this lasts for about 12 months, and as long as it's stored at about negative 25 degrees. And so this clearly isn't my area of expertise, so it might be a little bit wrong. I've seen minus 18, minus 25, but 12 months seems to be what I read in a lot of places. So the aphoresed cryo is about 2 to 2.5 the volume of a whole blood cryo. And so you can kind of halve the dose in terms of how many bags you need. And each bag of cryo is about 30 mils. So what is in cryo? So cryo's got kind of everything you might want and more. You've got about 338 milligrams of cryo, plus or minus about 125 mils from the lifeblood database. Per bag. So if you're giving an adult dose of 10, that's about just over 3 grams of fibrinogen that you're getting there. It's also got factor 8, factor 13, it's got some von Willebrand's factor, and it's got fibronectin. And I'll go into each of those in a little bit of detail a little bit later. It does not necessarily need to be ABO grouped. It's ideal if it is. There is risk of hemolysis with a large volume of un-ABO compatible transfusion, and so the practice, I'm sure, in our country is to ABO check. So I'll start with the negatives or the disadvantages. So I'm sure that all of you guys, or most of you guys, have probably administered cryo in your clinical practice, and I'm sure that none of you have got an overwhelming desire to do it again, or anytime soon. The 10 to 20 bags is definitely frustrating. It's slow. And then to add additional time to transfusion is that you need a 2-person independent check of all of these 20 bags. And so I think that's probably one of the main disadvantages of cryo, the way that I see it, where all we're talking about these days is the time to transfusion and the delays in replacing these products. In addition to that, it needs to be thawed. It only lasts for about 4 to 6 hours after it's been defrosted. So we can't, well, my unit particularly, we can't have bags of defrosted cryo just laying around because we'd throw a lot of it out because we wouldn't potentially use it. And so if I pull the trigger to actually, if I pull the trigger to give some cryo, it'll be 60 minutes if I'm lucky to get the cryo into my operating theatre at a major metropolitan teaching hospital in the middle of the city. And so that is substantially longer than what it would take if I asked for fibrinogen concentrate. Now, there's no known human risks or pathological risks at the moment to cryo, but I guess if history were to repeat itself, there has been some history of pathogens transmitted in blood products. So there is a theoretical risk of transmission of a pathogen in cryo because it's not a purified substance. And mathematical modelling of this suggests that that could be quite expensive if it were to happen. So look, that's a lot of bad-mouthing of cryo, I guess. What is the biggest benefit that I can see with cryo is that it's got all these other factors and cofactors. And so we'll start a little bit with factor 13. So factor 13 in cryo, so this allows for strengthening of the actual fibrin strands themselves. And then you get this, in addition to this, there's the cross-linking between the fibrin that we get with the factor 13. And so that is suggestive that you get a stronger clot that's more resistant to fibrinolysis. So overall, without factor 13, you may end up with what we'll talk about a little bit later in one of the studies. Von Willebrand factor, so quite an important little guy, carries factor 8, stops it getting degraded in the blood. But it also helps with that initial clot with the platelet plug and with the platelet activation at the site of endothelial injury. So without it, it's quite ideal. And then factor 8, so initiation, propagation of clot for obvious reasons, and then fibronectin. Fibronectin might not necessarily play that much of a role in hemostasis itself, but it might have quite a bit to do with wound healing post a traumatic event. So all of these things are a huge benefit that we have that in cryoprecipitate. It's cheap, or cheaper than Fibrinogen concentrate for sure. It's about $160 odd a bag, so $1,600 a dose, or thereabouts. And we'll talk a little bit more about that as we go along as well. And so we'll move over to the other guy. So Fibrinogen concentrate. This seems to be popping up all over the shop these days. I think in 2017 we introduced, or we got the license to give Fibrinogen concentrate at Charlie's. And we were one of the first non-trauma, non-obstetric centres, I think, in Australia to actually get the licence for it. And since then, I've started to see it pop up in one of the private hospitals where I do hearts, and in other places that I wouldn't quite expect it. So what is it? It's virally inactivated. It's a lipophilized powder for injection. It's reconstituted with 50 mils of water for injection, and it contains, Rheostat contains a standardised dose of 20 grams per litre, or 1 gram per 50 mil of solution. The dose is about 1 gram per 25 kilos, but these things have kind of changed over time, so we generally target to rotum and then give either 2 grams or 4 grams. But we'll talk a little bit about that in a minute. I think the biggest disadvantage of this guy is it only contains fibrinogen. So all of those other factors and cofactors that I just talked about, they don't exist in a vial of Rheostat. And so while you can give it quicker, you definitely miss out on a lot of the other additional beneficial factors and cofactors. It needs to be refrigerated. So this is better than minus 25 degrees of cryo. And so you can probably refrigerate a vial of this in an ambulance or a helicopter or an aeroplane. But it still does need to be refrigerated. So it's not yet strapped to your buddy with the grenades and the bullets, as you discussed with the plasma. But it's not as bad as it could be. Reconstitution. So there's only a few things that I've reconstituted that it's annoyed me more than Fibrinogen concentrate. And I reckon one of those would be teicoplanin. The only advice that I would say is don't shake it. If you shake it, you'll actually never get the clots out. The bubbles out, not clots. So nowadays I've got quite a nice little jig that you can use to reconstitute it and also draw it up via a filter into a syringe. And I think that takes out a lot of the kind of annoyance of reconstituting the Fibrinogen concentrate. It's expensive. It's $800 a vial. So if you're giving 4 vials, it's close to $4,000. And so if you can compare like for like, there is a cost difference between the two. And again, we'll talk a little bit more about cost effectiveness as we go through some of the studies. One of the other disadvantages is that in a lot of centres it still needs hematological or hematologist approval. We've got around that over years of use, wrongly or rightly, I might add. But in a lot of other centres, that additional phone conversation, the additional discussion of a case that might be quite complicated can delay the administration of it. Possibly not to the length of how long it takes for me to get Fibrinogen, cryo in my institute. So the benefits, look, it's definitely quicker. It's one thing I can say. Like we get it so quick, we can administer it very, very quick, and so we can come off bypass. We can have some rotum suggesting fibrinogen deficiency, and we can have that corrected before the wires are going in easily. And so that's one of the massive benefits. It's virally inactivated, which is useful. It's got quite a long shelf life. So 2 to 8 degrees it's stored at, and it could be stored for 60 months. And so we can stockpile these to a certain extent. There's a standardised dose of fibrinogen per vial, so we know what we're getting. The overall volume, look, it's discussed as being less, but it's marginally less. It's 200 mils compared to say 300 mils. So I don't think volume is such an issue in this regard. And the last thing from one of the benefits is that it doesn't require ABO compatibility, which is quite handy, but it still does require a 2-person check. So the pros and the cons, and so what does science think about this stuff? So I'll start off by saying this is I don't have time to go through each of the papers that I've chosen to talk about and kind of critique them. I'm just going to kind of provide a little bit of a summary in different aspects of feasibility, cost effectiveness. We'll look at some trauma, and then we'll look at cardiac, because clearly it's the one thing I know about. And then we'll talk a little bit about the FICE trial. So the first trial that we're going to talk about is the first trial. So this is a Canada-based trial. It looked at whether or not giving fibrinogen concentrate within an hour of injury was possible, and they found that it was possible, and that the fibrinogen concentration remained high afterwards as well. This is in about 50 patients, and then so 12 hours afterwards there was still a high concentration of fibrinogen per litre. And then we got to the UK. So this is Nicola Curry and her colleagues. They did a feasibility study, 45 minutes, and they found that actually it probably wasn't feasible. So a lot of the feasibility things that they discussed were methods to reduce the time of randomisation, which I think is more of a study design, more so than the feasibility of actually administering fibrinogen concentrate. But I've worked in the UK, worked a lot in the UK, and 45 minutes is not easy to do anything in the NHS at the current time. And then, so we'll talk a little bit about cost effectiveness. So there is a massive difference between the cost. But the guys that did the fibre study out of Canada, cardiac-based fibrinogen versus cryoprecipitate study, found that when they looked at all the costs, and including blood transfusion rates up to 7 days post-bypass, there was a cost effectiveness, or they were neutral cost between fibrinogen concentrate and cryoprecipitate. And we did some cost effectiveness stuff when we kind of launched into when we launched our license to get it, and we also found that it was cost effective. But I guess you can kind of make it cost effective for the people. But we wouldn't have got it at a public teaching hospital unless we could have actually had it coming close to equal between the two things. Fibres. So this was probably, at the moment, the biggest published randomised control trial looking at fibrinogen concentrate and cryoprecipitate. It was a planned 1,200 patient trial, non-inferiority. They stopped the trial at 800 odd patients because the interim analysis met the criteria for non-inferiority. And they found that there was non-inferiority to use cryoprecipitate or fibrinogen concentrate for some patients and that are having bleeding with hypofibrinogenemia after cardiac surgery. So we'll bring it back to Australia. So the FAST-1 trial, FAST looked at the time to transfusion between fibrinogen concentrate and cryoprecipitate. And so this also concluded that it was far, far, far quicker to give the fibrinogen concentrate compared to cryo. And so all of this looks pretty good for fibrinogen concentrate so far, until we went to our friends at Oxford with a small little sub-study, a laboratory-based sub-study. And then they took some confocal microscopy, had a look at some labelled clots, some fibrinogen that was produced after having either fibrinogen concentrate or cryo, and they concluded that the hemolysis kind of regulators were restored when you give cryoprecipitate compared to that of giving fibrinogen concentrate, and led to a stronger clot. And they produced this picture, and so this picture has haunted me, absolutely haunted me, every time that I mention fibrinogen concentrate. And so to talk this through, so this is our control. This is someone that's had no cryo or no fibrinogen concentrate. And this is the bright things are labelled fibrinogen. So you can see that this is quite a dense clot. Then you can see the pre-treatment dose with the cryo and the fibrinogen concentrate. They both look pretty, like they're not so dense. And then we look at the post-transfusion with the fibrinogen concentrate, and that looks pretty similar. Not a very dense clot. And then you finally look for the one that's actually had the cryoprecipitate, and it looks like a very nice, heavily dense clot that you're forming. And that's kind of reproduced up here. So you've got the density of the control group matching that pretty much of the cryo group. And then somewhere down here is our post-transfusion with fibrinogen concentrate. And so that's kind of shed a whole heap of doubt over whether or not fibrinogen concentrate is actually as good as cryoprecipitate for the treatment of bleeding. So ultimately, we don't really know yet. So this is what I do. I have to be very quick because we're running out of time. So we are heavily rotum guided. We are a unit that uses a very large amount of fibrinogen concentrate. We have treated about 230 odd patients at the end of last year. And as of yet, we haven't noticed any substantial kind of inferiorities anecdotally. We will look at this data and we'll see, and what I'm really interested in is to see how often these guys need some fibrinogen later on. So if we give them all fibrinogen concentrate in theatre, how often do they go to ICU and then score a bag of cryo to stop them bleeding? So our targets are Fib10 A5 of 12. If it's 7 to 10, they either get a dose of cryo or they get 2 grams of fibrinogen concentrate. And then if it's less than equal or less than 6, I couldn't put that symbol in, so I said less than 7. They get 4 grams of fibrinogen concentrate or 2 doses of cryoprecipitate. Now, I can tell you that since 2017, since we got it, there's colleagues of mine that are probably sitting in this room that have never administered cryoprecipitate again. I can also tell you that there's colleagues that I work with that probably have never administered fibrinogen concentrate. And I think that kind of reflects what's seen across the world, that there's a big difference in people's opinions about whether or not cryo or fibrinogen is correct. I certainly haven't seen this. I've seen these kind of normal rotums, normal coagulation profiles that still continue to bleed. I've seen that quite a lot, especially with the liver population. But when I've given fibrinogen concentrate, but the interesting thing is that they haven't corrected when I give a bag of cryo. So I don't quite understand that. I think potentially my population of coagulopathy is probably quite a lot different to trauma, to be honest. But I guess for the time being, let's just hold out for FAST-2. Thank you for your time.
Fantastic. 4 great presentations. Can I get the presenters to come up to the stage, please? Fantastic. So we've got 10 minutes.